So our next section is about breastfeeding support during a pandemic. And our first speaker is Dr. Nigel Rollins. He is working with the Department of Maternal, Newborn and Child and Adolescent Health at the World Health Organization, and has experience in breastfeeding economics and HIV and AIDS. And is going to give us a talk titled Supporting Mothers to Feed Their Infants Safely in the COVID-19 Pandemic, the Evidence, Health Workers and Society. So thank you very much, Nigel.
Thanks there, Elizabeth, and thanks to the whole team who've been organising this for the kind invitation. And I should Julie had mentioned my name a couple of times. I should just say that all the economic work was largely the work of Susan Horton up in Canada. I'm a paediatrician than an economist, but thanks for the recognition of work which was by a whole team of people. So Elizabeth had asked me to share a little bit about COVID-19 and the pandemic and the impact on breastfeeding. And it's certainly been something of a tsunami, I think, in all of our lives. And with that, certainly our world at WHO has been really overtaken by this, and including issues around breastfeeding. So let's just see, I just wanted to go forward. Sit there. So I think we all recognize, oops, it's gone a bit too far. So I'm just going to learn how to use this. And since the emergence of both the virus and then symptomatic COVID, there's been great uncertainty about whether the virus itself is transmitted. There's been reports about RNA, and I'll come back to that a little bit later on. And these uncertainties have led to inconsistency between many of the national health agencies and what they say about breastfeeding. And I'm also including mother-infant contact because it's very hard to separate the two. And a Cochrane review was published in April, and they looked at the guidelines in 19 countries. And what they basically found, and there have been other studies that have been replicated and updated since then, is that there has been a lack of consensus, or certainly back in April and May, there was a lack of consensus about what authorities should recommend about breastfeeding and contact. So without going into the numbers here, you can just see that there is inconsistency between some authorities saying, yes, breastfeeding and contact is contraindicated, others saying that they would consider it, others saying that no, it's not contraindicated, but it's certainly been unclear what the policy, the global view of this would be. And this is not unfamiliar. We've seen things like this during the time of the HIV epidemic. And unquestionably, this has led to confusion amongst health workers and communities regarding appropriate infant feeding recommendations and practices. And what we've also been seeing is that breast milk substitute marketing has been claiming protection and exploiting the vulnerabilities and the uncertainty amongst communities. And I just saw this earlier today, that there was the publication of a survey, a national survey in Mexico, and 2/3 of mothers in Mexico say that they should not breastfeed if they had COVID. So there's clearly an inconsistency between how people look at the current evidence, how they interpret it, and what are the messages going out to both health workers and communities. So what I want to do is to look a little bit at the available evidence around some of this, and just to say that as far as I'm aware, this is really as much as we really have. There are pieces of work ongoing, and Natalie made reference to work, for example, on antibodies in breast milk, which I think is still going to be coming in the next months. But at the moment we have, or in the middle of August, we have reports about breast milk analyses and transmission data from 175 mothers from different parts of the world who had confirmed COVID-19 symptoms. and samples from 10 of these mothers tested positive for SARS-CoV RNA. Now, this RNA fragment of the entire section of the virus is not the same thing as the whole virus, but this is what the RT-PCR test was able to detect, and it's a very sensitive test. Infant status was not consistently reported amongst these mothers, but amongst 46 of the mothers with confirmed infection, 13 of those 46 infants tested positive, but their feeding practices were not reported in the publications, and 1 of 3 infants tested positive, but again, it was unclear the source of infection, whether it was due to the ingestion of breast milk or because of droplet spread. And then there were 2 particular reports that I want to draw attention to. This is the first report from the team in Germany, and they detected this SARS-CoV RNA in breast milk being present for over a 4-day period. And 1 of the 2 infants in the study became infected and the other one didn't. But they detected this, this fragment of the virus over a period of 4 days. A study that came out then more recently in July was by Lars Bodes and Christine Chambers' group in San Diego. And they had very detailed analyses of breast milk from 18 infected mothers. And they again looked at multiple samples, 64 breast milk samples in total, and only 1 of those samples also showed the same SARS-CoV-2 RNA, and that was on the first day of symptoms, and it was negative thereafter. What this study did that no other study has done before is that they also developed an assay to see whether the virus that they were able to identify part of in the breast milk, whether that virus was able to replicate, infect other cells, and thereby to transmit infection. Because unless you're able to demonstrate that replication, that virus is not capable of transmitting infection. And there have been no studies, and certainly in the work from San Diego, the virus that they identified was not able to replicate and transmit. So at this point in time, we don't have evidence of transmission risk through the ingestion of breast. And this caused us to look at what would public health policy look at. So WHO does have a clear statement where we say that breastfeeding should continue. There's no reason to separate a mother from an infant. But we stood back and said, what would be the conditions whenever breastfeeding and should be discontinued and when separation might be justified? And we started from the point that public health policy should be evidence-based, even if the evidence base is weak at any one time. And so there are several considerations about how commonly do you find COVID amongst mothers, what's the actual transmission risk, and how severe is that infection in infants if they do get the infection. And we should be comparing that combined risk with the risk of not breastfeeding, including initiation and also separation of the infant. And I'm going to run through this fairly quickly. But essentially, from a public health perspective, you would argue that policy favoring avoidance of contact and non-breastfeeding would be supported if these 4 conditions. I'm just going to close off. First of all, whether there was significant infection fatality in the infant associated with COVID-19. If there were low health, adverse health outcomes in the event of separation and the use of breast milk substitutes, if there was significant transmission, and lastly, if it was straightforward to actually identify SARS-CoV-2 infection in the mother while she was infectious. Because if you didn't have that, then you can't actually implement the policy. Conversely, we said that policy would favor continued mother-infant contact and breastfeeding if there was low mortality risk associated with COVID in the infant, if there were immediate survival and long-term benefits of breastfeeding and contact, and there was then a low risk of transmission, and that there was challenges in actually identifying SARS in mothers while she was still infective. And what we then did was that we undertook a modeling exercise. And I want to acknowledge Nicole Minkas, who's based in London, Neff Walker and Cesar Victora. Some of you will know their names. And what we did was that we looked at what might be the COVID-19 related mortality in neonates and infants. And this is really a function of how commonly would you find SARS in mothers at birth or through the first 12 months, what would be the transmission risks, and what's the infection fatality rate. And then we looked at what would be the comparison. And again, we would say, what's the incidence of SARS-CoV-2 in mothers at birth and through the first 12 months? And if you identified this infection in all the mothers during a time whenever she was still infectious, and you then stopped breastfeeding, what would be the increased mortality risk that would then follow? And we looked at it by different countries and their background infant and neonatal mortality rates. And I'm really just going to jump to some of those numbers now. We use a modeling tool called LIST, which some of you will say, I won't go into it in any detail, but it models these numbers out across 119 low and middle income countries and estimates the impact amongst 104 million newborns and infants. And these are the results. Essentially, assuming that about 10% of mothers at any one time might have COVID, which might even be a high estimate, even though we don't have any evidence of transmission to neonates and infants, we assume, let's say 20 or 30%, and we assume a 0.09% fatality, even though this rate is amongst symptomatic infants. Then amongst 104 million births in infants across these countries, you would have a total of between 1,900 and 2,800 deaths in total. If you were to compare that then with the mortality due to separation and breastfeeding, we looked at two scenarios. One where breastfeeding stopped and there was no restart, and then a second where 50% of the neonates and older infants restarted breastfeeding or stopping. And in the first scenario, you would have about 273,000 additional deaths. And if there was 50% restarting of breastfeeding, then you would have around about 188,000 additional deaths. So that would be, even with the most conservative of estimates, and we were extraordinarily conservative, that would be an over a 60-fold difference in mortality by implementing a policy of stopping breastfeeding and separation. So it's really striking, how is it that national authorities have interpreted the data so very differently? I want to jump very quickly to some of the reports about practices and experience of mothers. And this was a publication by Amy Brown not all that long ago. It was an online survey amongst 1,200 breastfeeding mothers. 40% of mothers felt that breastfeeding had in fact been protected due to the lockdown, whereas about a quarter of mothers struggled to get support with some breastfeeding early. And not surprisingly, the greater challenges and the greater likelihood of stopping breastfeeding was amongst the lower educated, those with more challenging circumstances, and amongst some of the ethnic minority backgrounds. There was a recent survey by UNICEF, and they identified the same sort of findings. 88 countries, most countries that they surveyed were supporting mother-infant contact and breastfeeding. Many recommended breast milk substitutes if mothers were unwell. There was large-scale disruption of services. And one of the interesting things was that they were exploring mobile phones for providing remote support to mothers who were unable to access health facilities. So WHO, we provided a series of frequently asked question documents covering many things like can or should mothers with confirmed COVID breastfeed? What are the alternatives? What about wet nursing? And I'm not going to go into any detail on that now, except to say that type of resource is available. So really, in just trying to conclude, the COVID pandemic has amplified many of the inequities and vulnerabilities within society and within our health system. The impact on infant feeding is emblematic of many of these challenges. However, at the moment, WHO is fairly clear that the current evidence and balance of risk estimates strongly support continued mother-infant close contact and breastfeeding, even whenever mothers have confirmed infection. Public health authorities should really be understanding the full scope of evidence and implications, not just for COVID infection, but all-cause mortality and other outcomes. And those messages need to be clearly communicated to health workers. Breastfeeding counselling and support is essential during this time, both to continue breastfeeding and also to reduce the small risks of transmission through close contact. And lastly, public health authorities and legislators need to proactively address the deliberate exploitation and seeding of doubt about breastfeeding by commercial interests, even during such vulnerable times as these. I'll finish there. Thanks there, Elizabeth.
Thank you so much, Nigel. That was really great. And thank you for those really wonderful conclusions there. So our next speaker is Professor Sue Carter, and she's dialing in from America. Sue is a professor, a distinguished research scientist at Indiana University in Bloomington, and she has wide and extensive expertise in the endocrinology of love and social bonds. Her title today is The Evolution of Love, Lactation and Oxytocin and What Makes Us Human. Thank you, Sue.
It's really a pleasure to be here. My ancestors came from Ireland about 200 years ago to the United States. So I feel very close to the country. I want to talk about basically oxytocin, since we have very little time. But most of you know that lactation is a major source of conveying the hormone oxytocin from one individual to another. At the same time, the same behaviors allow us to develop loving relationships. Love, which I'll define in a moment, is necessary for survival and also reproduction. So the way I like to define love is as a complex of neurobiological processes that facilitate health, wellness, reproductive fitness, and biological optimality. And what science teaches us is that the biological and evolutionary prototype for love is actually the parent-child interaction and all of its features. At the same time, humans are wired to also have fear. We have to defend ourselves both by positive behaviors and negative behaviors. Both love and fear have survival benefits. Love can overcome fear, but exactly how that happens is only now becoming apparent, and oxytocin is part of the answer. So the evolutionary and biochemical prototype for love, of course, social bonds in mammals, and this is very much a mammalian hormone, is the mother-child interaction, including both birth, but especially lactation, which gives us a long-term interaction with our babies. So these secure bonds and attachments that are really, we now know, the basis of good mental health are formed early in life and they depend very much on this hormone oxytocin. Fathers and mothers actually release oxytocin when they're with the baby, and it protects both of them from the stress of child rearing, but especially the mother. So oxytocin sits at the center of a whole complex of events. Reproduction, of course, but also, and social bonds, but also resilience and survival on both the part of the mother and the baby. The oxytocin hormone, it's important to know a little bit about it because its biochemistry explains why it's so powerful. The hormone is formed of a ring and a tail, and the little circle I have on this slide shows you that the connection in that ring is a sulfur bond. And I mention this because it's an extremely powerful bond that can both open and close, and accounts, I believe, for many of the benefits of oxytocin and indirectly lactation. So, of course, oxytocin was thought to be a female reproductive hormone, primarily acting on the uterus and the mammary gland, but that was only part of the story, very small part we're discovering. And we now know that oxytocin affects both males and females and affects both the body and the brain. Oxytocin is made mainly in the nervous system, in the hypothalamus, and that's important to how it works. It's released into the bloodstream at the posterior pituitary, so that's the classic story. But we also know that oxytocin is released within the nervous system, and it can affect social behavior. It regulates the autonomic nervous system, especially important right now, as the last speaker pointed out, the immune system. And that's what I'll talk about in a moment. And what it does is bring all of that together so that we can adapt, protect, and heal in the face of challenge and stress. So the evolutionary part of this story is very important to keep in mind. Our ancestors were reptiles. The origins of mammal come through a reptilian ancestor, and oxytocin actually allowed that to happen. It allowed the transition from reptile to mammal in several ways. First, it permits birth, and especially in humans, I think it's more important than small mammals because it helps expel the big-brained baby from the uterus, and that big brain is what makes us novel. It facilitates postnatal, post-birth nutrition, and it supports the baby by creating a bond. Oxytocin also facilitates oxygenation of the brain. It's a component of the vagal system, the autonomic nervous system, a so-called myelinated vagus that allows social engagement to occur. And oxytocin permits social cognition and human behavior. In fact, I will argue that we're here today because of oxytocin. We wouldn't have the complex cultures, societies, certainly not the electronics that allow us to be here today. So the problem that humans faced was when we went from our ancestral, we presume ancestral form, had walked on 4 legs, did not depend on upright mobility, and had a bigger pelvis. As we, if you pardon the expression, evolved, we developed special problems because we had a small pelvis that was rigid and fixed, allowed us to be mobile, but also made it difficult for this big cortex and skull to be extracted, taken out. Oxytocin facilitated that kind of birth, and of course left us, the pattern of human evolution left us with an immature baby, big enough to breathe on its own and do certain functions, but not able to feed itself. Okay, we got too fast there. So we have this, if you will, this is not a progression. We did not evolve from chimpanzees, but you can see the differences in the size of the cortex shown in this picture, as opposed to a reptilian, not ancestor, but again, example in the crocodile, which has a tiny little brain. So this nervous system that we were able to create allowed us to have love and attachment. I'm going to skip the next parts because I think we're running a bit late. So what I will tell you only is that there is a second hormone in this story, and to really understand oxytocin, we need to understand vasopressin, which is an ancestral hormone that is much more primitive and serves the purpose of self-protection. Oxytocin overrides this. Oxytocin's about a little over 100 million years old. Vasopressin, 250 million years old, and the original vertebrate ancestor about 600 million years. So we've had a very long time to make oxytocin do its magic. And again, because of time, I'll only show you that oxytocin is really the hormone of mammalian sociality. It promotes approach behavior, it allows us to relax. It is for many forms of resilience and immobility without fear, our capacity to pick up a baby the day it's born, put it to our breast, and let that baby be part of our lives. And because the parasympathetic nervous system is so important here, the vagus nerve and oxytocin are really one story. So what I like to say is that oxytocin is a metaphor for safety. The ancestral hormone, much more a metaphor for active protective responses, but dangerous in many ways. So we have the capacity to form social bonds, to fall in love with our babies, to be calm and safe. And that's all promoted by keeping the source of oxytocin, in this case, lactation, going. Lactation is really a maternal insurance policy for both the mother and the baby. What's really important, this slide, which is extremely complex, makes one point. Oxytocin, as well as this companion hormone, are part of the autonomic nervous system. Oxytocin in particular regulates the vagus, and the vagus in turn regulates inflammation and healing. There are a number of disorders, I won't go through them, linked to oxytocin deficiency. Almost all of what we call mental health has a positive, oxytocin has a positive effect, and especially physical health, and especially the immune function. This is all linked by this relationship between oxytocin and the autonomic nervous system. It's an integrated system. So I end by showing you what you already know. This is the power of love. It originates in the biology of birth and is reinforced continuously by lactation. It allows us to bond and to support others throughout life. Dostoevsky says the soul is healed by being with children. It's, of course, absolutely critical that we support and love the next generation. Lactation is the way this is carried out. It allows us to have that love and strong connection that are strong medicine. Thank you.
Thank you so much, Sue. Really important work on oxytocin and how it optimizes humanity. Thank you so much. So we're going to move on to our next speaker, is Dr. Elizabeth McCarthy, co-organizer and co-host, whom we didn't get to introduce earlier on due to technical issues. But Elizabeth is now going to speak. Her title is A Qualitative Exploration of Breastfeeding Support Groups in Ireland from the Woman's Perspective. Elizabeth is an academic researcher now working with NUI Galway. She's also an IBCLC and a peer support worker working with Lalish League. So thank you very much, Elizabeth.
Thank you, Sarah, and thank you, Eileen. Apologies for the IT issues earlier. So I'm going to discuss a paper that I published last year, which came from my PhD. And just moving on. Sorry, yes, okay, so that's the paper published in Midwifery. And here we go into this main part. So I quite like my art, so sorry, they just seem to be moving on a bit quickly here. All right. Okay, so I'll be interspersing these throughout, the little paintings that I quite like. So the background to breastfeeding, why did I do this study at all? So there are significant positive long-term impacts for mother and child, and several references there also to my good colleague here, Nigel Rowlands, who's kindly joined us, about the short and long-term health, economic and environmental benefits for society. And I think while it's well known that there are all these benefits for society, unfortunately in Ireland we have the lowest rates in the whole of the OECD by quite a long way. And even though it is appreciated that breastfeeding is the norm, the biological norm, it's not the cultural norm, particularly in Ireland. And the reason for my PhD originally on this paper was that women's perspectives on breastfeeding support are not well researched. So while there may be many articles from a health professional's view or on health professionals who initiate and facilitate breastfeeding peer support, not on peer support directly, and I'll go on to give the definitions on the peer support. Sorry, the lex not, yeah, okay. So there are tensions and contradictions in that artificial feeding is viewed as the cultural norm in Ireland, according to literature in Ireland. Although mothers are well aware of, and I don't yet like using the term health benefits because it is the norm of breastfeeding for babies. So there's a disconnect between policy and what's happening on the ground. So the aim was to explore women's experiences of breastfeeding support groups from their perspective, bearing in mind that this research was all carried out pre-COVID. I will ask the question at the very end, where do we go from here in our new normal, where mothers cannot actually see each other in a group face-to-face. So peer support is systematic support between two persons or in a group where the participants are equal. Usually experienced breastfeeding women who are outside the woman's existing network, so not necessarily not in the family, but other women who they perceive as being similar to them. And participants it's a dynamic, so it's a two-way process for mothers who are considered active participants in that process of support. So just a little study I did a few years ago kind of highlights how low at that stage, and it's not much improved, how Ireland relates to other countries who are also English speaking and of similar cultural background. So the 6 main themes that occurred in the qualitative aspect of my mixed methods PhD was the complexity of breastfeeding support, community and connection, the impact of culture, the journey, many mothers refer to the breastfeeding journey, the passing on and what mothers want. So I just quickly go through these and a few quotes. So this is Nina, who's talking about everyone's telling you what to do, but there's not actual practical help as such. Many mothers go to multiple sources of support, which is wonderful because we're all doing the same thing in the end. So while La Leche League is there, and I am a La Leche League leader, all my colleagues in Cuidiú, Facebook groups, the Friends of Breastfeeding, and so on, we're all trying to do the same thing. We all collaborate together and we all get on really well, and that's really good because it's not a competition between peer support groups. We're all there to support the mothers. So this particular, I hadn't included the public health nurse groups initially in my study, but I felt I had to. So in Ireland, the public health nurses are running breastfeeding support groups locally. And because all the mothers seemed to be going to them, actually, especially in the first 6 weeks, I did include them then because they were used as a stepping stone onto others' peer support later. So it was like a natural movement on from the initial meeting of other people. So in community and connection, really mothers go to meet other mothers. That is the main reason that a mother goes to a breastfeeding support group, and not necessarily with a problem. To have a one-to-one contact with other people. As all of you who are breastfeeding supporters on here or involved in any type of breastfeeding support, you will know that the food and drink is probably the most important part of the whole thing. And it's sometimes some groups were struggling initially, certainly with the PHN groups, because of not being able to share food. But this has going to have implications from now on, which are new normal, when mothers cannot physically get together, because it was the home baking and it was nurturing through the tummy, as Lisa described it, and when people share food together. That's what's so important. So the issue of the safe space, also, that mothers felt that it, probably even the way the room was set out was very important to facilitate conversation where you can relax. So it was more homely. However, a lot of groups are now meeting in restaurants and public spaces, and that's great too, because it makes breastfeeding more visible, but also it can also be relaxing. The groups, they felt that the convenience and location of the groups were very important. Again, that's something we need to think about now during the pandemic, as mothers are accessing a lot of online. So it actually probably doesn't matter for the moment where one lives to access a breastfeeding support group if it's online. So the impact of culture. So even experienced mothers who had a baby before and breastfed still felt on their second, third baby or more that there was always a few little niggles, because each baby is different and each mother is different at that stage of her journey as well. So some mothers go along again on second and third baby, but also for the fun and the food as well, and the friendships. Family can be positive, but they can also be negative, particularly if they haven't had direct experience of breastfeeding. And then we were onto the journey itself. So ages and stages seem to be quite important. Mothers did speak about being friends with other mothers who had babies who were similar age and stage. They felt they identified with them, but they also loved the fact that there were mothers ahead of them in their journey, and also the new mothers coming up behind. And also the journey itself is up and down and has different stages and brings you to a place. Again, the friendships I mentioned, just to make a note that all of the photos that I'm using in this slideshow, I have permission from all the mothers to use. And some of these are from La Leche League Trinity group, which we're meeting in the pavilion on campus. So yes, lots of friendships came out of that group, but of all groups they do. Mothers talked about having goals, and wanting to reach those goals, and every mother's goals are different, and sometimes they change as the journey proceeds. Some mothers may start off with a goal of, feeding for a certain amount of time, and then find it changes. This was one of quite a strong theme of passing on. Mothers spoke of the very strong need they felt to be a role model for others, but also to pass on to other mothers what they had learnt, sometimes the hard way, but also to pass on the positivity that things do change. While there might be issues in the beginning, it will pass. So empowering other mothers. So mothers felt a very strong need. They talked about up-to-date, correct information, really trying to counter any negative or incorrect information that mothers may have heard or been told. So what do mothers want? So they wanted breastfeeding solution. They would like breastfeeding supporters to be trained. They want to get support from people who have breastfeeding experience, and community breastfeeding promotion to be more visible. The experience of another mother having breastfed herself is quite powerful, actually. That does not mean that people who haven't breastfed cannot support mothers. Of course they can. But it does add that extra for the mothers, that they feel they're talking to someone who's been in their shoes. So solutions they wanted as well. They wanted practical solutions that they could work out together with another person, which is why they really valued peer support particularly, because they didn't feel they were being told what to do or having a judgment, even though I do know that all my gigs in the lactation world, sorry, this seems to have gone off by itself. We'll try and get back to it. Do not ever pass along judgment or expectations on a mother. Everybody's trying to help the mother to achieve her own goals. Sorry about that. I'm just going to go swiftly on to get back to where I was. So yes, they felt that it was important to be able to access accurate sources of information that they could use, along with bringing, because breastfeeding supporters, when they provide this sort of information, they always suggest to mothers that they bring it with them to discuss with their health professional. Okay, so trained supporters. So it was like they were just there to meet up. Some mothers felt that when they went to some groups, particularly perhaps in a coffee morning session, sorry Eileen, it's happening again there now. Yes, thank you.
You want to tell me to move to the next slide? It's
yeah,
easy.
Please do. Yeah, please, Eileen, thank you. So some mothers, maybe when they were in a group, especially if there was a lot of people, if they were shy or whatever, sometimes that was difficult for them to come forward, and sometimes they felt a bit excluded. So sometimes something for that most peer support groups are, well, all peer support groups are aware of, but it's something that we all need to individually be aware of, that not everybody is forthcoming, and confident to speak up in a large group. Next slide, please, Eileen. So yes, the breastfeeding experience was very important, that for mothers, that they felt, at least if they were talking to someone who had breastfed before, that they know what the struggles were and they were in their shoes, as it were. Next slide, please, Eileen. So a lot of the mothers felt strongly, and it's like other issues we were talking before with previous speakers, that breastfeeding is a community and society issue. It's not an individual mother issue. It's very difficult for a mother to sort of battle away if she wants to breastfeed without support, perhaps in her immediate family and community, but also in the wider community, that if it was more acceptable as being the norm, which other speakers are going to talk about in other contexts, that it might be that bit easier for them. Next slide, please, Eileen. Great, so this is my pre-COVID group and then our during COVID. So many La Leche League leaders, Cuidiú and Friends of Breastfeeding and so on, all around the country, running online groups and doing the best we can to support mothers, particularly in these very challenging times for mums and their babies and their families and partners. So breastfeeding supporters, yes, unfortunately my another paper will have to be written on the post or during COVID situation. So last slide, please, Eileen. So that is my question, which I cannot answer today, I'm afraid, and it'll be for this time forward. I know Nigel did do very good talk there on the COVID situation, so I'm very delighted to cover that. And thank you very much, and enjoy the rest of the webinar.
Thank you so much, Elizabeth. That was really enlightening to hear about the experiences of mothers accessing peer support groups around Ireland. So now we're going to have the Q&A session, and Carter will not be present at this Q&A, but will come back hopefully for another Q&A. She has another conference that she's attending in Spain, and that's another beautiful silver lining of COVID, that we can, all of the expertise that's been shared here today can be shared all around the world for us to learn from. So if Nigel could turn on his camera and mic as well. Please, thank you, Nigel.
Trying here. Hi there, Eileen. It's not sharing the video, but maybe you can hear me. I'm there now. Yeah.
Great, thank you. So, Nigel, we have a question here from Maria Hearn. So, wondering why the WHO are taking a cautious approach to promoting breastfeeding during COVID, just in terms of the language that they're using. So, if women wish to breastfeed, I'm just wondering what you think about that.
So, I don't think it's as I think WHO. I mean, I put a message in the message box there in the chat box, that I think WHO is pretty clear that, and if I go back to that statement of what's there in the thing, it says that, you know, it asks the question, if a mother is confirmed suspected to have COVID-19, she continue breastfeeding? And the answer is yes, high quality evidence, and then it carries on about the health benefits of breastfeeding and that transmission's not being detected. So I think actually it's been pretty strong in its support. I think it's not unreasonable to say that there are women who choose not to breastfeed, and as I'm sure people will agree, that we shouldn't be, you know, industry does it, and it exploits this and the vulnerabilities of this and the fears and the worries. We shouldn't follow the same example, but I think that, you know, women who want to breastfeed unquestionably should, and WHO says that the same infant feeding recommendations are absolutely the same in the context of COVID. There is no change in that. So I'm not so sure whether I agree there, Eileen, that WHO has been ambiguous on this.
Okay, and of course, like your conclusion slide, we're very definite about the benefits of breastfeeding and how they outweigh the harms of not breastfeeding in the context of COVID, and that's very important. So
I think one point I would just raise there is that there's often very careful phrasing, that the reason for supporting breastfeeding is not because transmission rates are low or doesn't occur. Because I think if that is our primary argument, and there is even one case of transmission that's proven, it undermines the argument. The overwhelming argument is the benefits and the advantage of breastfeeding compared to anything else. So I think in terms of our language and our approach, we should not be relying on the fact that transmission has not been demonstrated. The overwhelming argument is that breastfeeding is just so much better for health, and the risks of any infection, even if it does occur, are so low in the young infant or child.
Mm-hmm. And it's similar to the WHO's perspective with HIV and the overall benefits of breastfeeding. It's a similar argument that of course breastfeeding has so many more advantages than any substitute feeding. Yeah. So thank you very much, Nigel. Elizabeth, I'm kind of just a little question for you in relation to your research. So COVID changed everything so dramatically for mothers, and Amy and Natalie did really great research looking at the experiences of mums during COVID. Have you any insight on that in Ireland? What's happening at the moment in Ireland, or in relation to how COVID is affecting us in Ireland, where we have a really high prevalence of formula feeding? And
there's mixed, I mean, there's probably a lot of research that could be done on it, but just for my own personal experience of running groups, the breastfeeding support groups have really taken up the slack there, really, because mothers are going into hospital, they're having their babies, they often don't have their partners with them. They don't have, in full lockdown, when we had full lockdown, they didn't have access to any family supports, which was positive and negative in some ways, in that perhaps if mothers were breastfeeding, they weren't getting any negative comments, but also on the other hand, if they needed support, it was difficult for them to see anyone face to face. Now, having said that, certainly with La Leche League, have always run breastfeeding support by telephone, because that was the new technology in the years gone by. But certainly the online, mostly Zoom is mentioned, but there are lots of different forums. I certainly fill the space a little, but I don't think it can replace the face-to-face support, because just even looking at some of my slides and pictures, the fun and the enjoyment that women are get out of meeting each other, and often they end up maybe not talking about breastfeeding at all. It could be things they have in common, and the networking that they do from that is probably not as easy to do from online. However, WhatsApp groups arrive out of these groups, and mothers join the WhatsApps, and they're able to support each other, and we're able to support them that way too. So I suppose it's a short time, Sarah, to answer your question, really. We won't really know what the fallout has been for some time, but certainly mothers are struggling in trying to access services, perhaps, the health services as well. But certainly the breastfeeding support groups have come up to the plate. And I think if it wasn't for them, I would be very, very concerned about a new mother's welfare, particularly someone who wants to breastfeed, because often the issues are not easily dealt with, but they may need just a word of encouragement, or just that's okay, and this will pass, those sort of things. But sometimes, there are mothers who need to be seen directly, and that's the problem. I don't know if that answers your question, Sarah, enough.
Yes, thank you very much, Elizabeth. Yes, it does. We are trying to, in this time of COVID, to connect as much as we can, despite the absence of our capacity to connect physically, which is so important. But again, like you say, it's building other really important methods of interaction. And hopefully, as time goes on, the physical interaction and connection will start flourishing again. Yeah. Thank you.
Okay.
Okay, so thank you to Nigel and to Elizabeth for that really interesting section, and also to Sue, who's not here for the Q&A, but who will be back hopefully later on to answer the questions. And so for the next question, I'm going to hand over to Elizabeth to moderate the next section.